Good morning. I want to welcome all of you to this event on metastatic breast cancer. I'm Dr. Nancy Davidson. I'm a leader at the Fred Hutchinson Cancer Research Center, and I hold the Raisbeck Endowed Chair for Collaborative Research. I want to thank you for joining us today. Myself, Dr. Kevin Cheung, and then also my colleagues from the advocacy community, Lynda Weatherby. We are so happy that you're able to join us today. I especially want to thank Lynda Weatherby and Terry Palastro for their help with today's event. Both of them are metastatic breast cancer patients and advocates, and so they have given to us a list of questions that we thought that you might like to have answers to. Now, to get us started today, I want to think a little bit about who you are and what we want to accomplish. We know that you're an incredible group of people. You're passionate about research in this area. You're smart, you're well-informed, and like us, you're really dedicated to finding a cure, and we thank you for that. Now, we know that this research means a lot to this community, whether you're personally living with metastatic breast cancer or whether you have a loved one with metastatic breast cancer. We know that there is far more metastatic breast cancer than we would like to see, that 1 in 3 individuals who receive a breast cancer diagnosis will either present with metastatic disease or their early stage disease will progress to metastatic breast cancer at a later date. And obviously that number is far too high. It's unacceptable. So Dr. Cheung and I are here today because we want to give you an update on what the Fred Hutch is doing in this area to try to understand and find treatments for metastatic breast cancer. And you also have a chance to hear from Lynda Weatherby, and all of us together will try to answer your questions. Now, you may or may not be familiar with Fred Hutch, but we want you to know that our mantra at Fred Hutch is cures start here. Cures start here. Now, we've already developed cures for some kinds of cancers, and we really are dedicated to ensuring that cures exist for all cancers. Hutch is also synonymous with fearless science. Cures start here, fearless science, that's as true now as it's ever been. And philanthropy makes fearless science possible. And again, we're so grateful for your support. Now, let me tell you a little bit about what's going on in this field at Fred Hutch. First, I want to remind you that a year and a half ago, our new president, Dr. Tom Lynch, joined us. And he is himself a medical oncologist, interested in the lung cancer space, but lots of commonalities here. And of course, he, like all of us, is very focused on finding cures for metastatic disease of all type, including breast cancer. And as a consequence, we've been busy growing our program. And just in the last 6 months, we've been able to recruit 2 new faculty members coming into our institution and into our team to try to think about important issues. First, I want to introduce you virtually, if you will, to Dr. James Alvarez. Now, James is a basic scientist. He's a laboratory-based scientist. And he's been working at Duke University in North Carolina in the Department of Pharmacology. And his interest, his passion, is in deciphering what breast cancer cells are doing during a long dormancy period before they might recur. He's looking at 3 different lines of investigation. Dormant cell metabolism, these cells that might be lurking in the body, just sitting there in a kind of senescence. How is it that they continue to live? Genomic instability and heterogeneity during the tumor recurrence. What are the changes in the genomic code, the DNA code? And then finally something called epigenetic rewiring, another process that allows the tumor cell to try to figure out how to adapt and to get around and to be able to continue to flourish. So James joins a very rich group in metastatic disease, Dr. Cheung, who you're going to hear from in a few moments, and also our colleague, Dr. Cyrus Kajar, who's also very interested in these same mechanisms, and again, in breast cancer. Now, on the other end of the spectrum, we're going to be joined by Dr. Vita Henderson. Vita is a population scientist. She's a behavioral scientist. She's a minority health researcher coming from the University of Illinois, where she has been working in the School of Public Health. And she's going to really focus on breast and cervical cancer prevention and early detection. She's especially interested in cancer disparities and preventive health services utilization. And so this is another really exciting area for us to be able to think about how we might be able to detect breast cancer in a way that we would ultimately prevent the diagnosis of metastatic breast cancer. Finally, I want you to know that there's a big effort going on, Ryan, to recruit a new leader to our group, a more senior scientist who would be able to serve as one of the leaders of the breast cancer group and to help us to be the glue between our laboratory-based efforts, our population science efforts, and our clinical efforts. And we're happy to report to you that that work is going on very nicely, and we hope we'll be able to locate and attract such an individual to join our community in the relative near term. Now, one thing I also want to assure you about is that you may have seen in the news some months ago about ongoing efforts that are looking to exploring whether or not we can bring the Fred Hutchinson Cancer Research Center and the Seattle Cancer Care Alliance into one organization called Fred Hutch Cancer Center. This effort at integration is continuing very nicely, and I think it will allow us to be in a position where we can be even at the more at the forefront of trying to identify the important scientific opportunities that exist in metastatic breast cancer and to think about how we can use them to deliver true results in the context of the clinic. Now, I want to speak briefly as somebody who's worked in metastatic breast cancer for a long time, several decades, and just to let you know that a lot of progress has been made, though it's far from sufficient. You know, when I think about the new treatments that have come on board for metastatic breast cancer over the last year or 18 months, even in a time of COVID, it's truly breathtaking. We have new agents that are being brought to bear for the HER2 positive type of breast cancer. That type of breast cancer, when I started in our field, was a very, very, very difficult subset of breast cancer and frequently lethal in a very short period of time. Thanks to our understanding of HER2 signaling pathways, we now have a multitude of agents that are available to try to target HER2 positive breast cancer, both in the early stages to try to prevent it from ever returning, but also in later stages if it's necessary to try to control the disease. Similarly, in endocrine therapy, new agents that have come on board to help us to try to think about treating hormonally responsive breast cancers, things like the CDK4/6 inhibitors, palbociclib, and related drugs that have come into our armamentarium just over the last 5 or 6 years. And then finally, some headway being made in the triple negative breast cancers. You know, those are the breast cancers that lack the estrogen receptor, the progesterone receptor, and the HER2 protein. And so these are ones that have been quite difficult for us because often it is the chemotherapies that are the most effective. You know that work is going on right now looking at some of the new immune therapies in metastatic breast cancer, and that's the particular subset where they might be the most useful. We've also come to realize that in some cases, these triple negative breast cancers exist in people who have BRCA mutations in the BRCA1 or the BRCA2 gene. And those types of tumors seem to be particularly susceptible to yet another kind of drug called the PARP inhibitors. So these are all new approaches for the subtypes of breast cancer that have come onto our horizon over the last, in some cases, a couple decades, and in some cases, several years. And where we're able to now to try to think about how to deploy them to maximize outcomes in metastatic breast cancer patients, but also to think about where we might be able to use them in earlier breast cancer to try to prevent the diagnosis of metastatic breast cancer. So with that introduction to our institution and to a sort of a state of the union about where we are in metastatic breast cancer right now, I want to bring on the screen my colleague, Dr. Kevin Cheung. I'm delighted to be with Kevin today. Kevin is a physician scientist who studies the origins and vulnerabilities of breast cancer metastasis. He focuses on something called collective metastasis. And as he'll tell you, that's the concept of the spread of tumor cell clusters to distant organs. Now, he and his team have been able to unravel how breast cancer metastasizes. And they're doing this because they want to be able to use this knowledge to develop more effective treatments and prevention strategies for metastatic breast cancer. And so we're going to have a chance to learn from Kevin about this work and get an update directly from him. So Kevin, tell me about what your group is doing. What have you learned about how breast cancer metastasizes, and what did you expect, and what surprised you about this research?
Well, first off, thanks, Nancy, for having me. It's really great to be here in this very important forum. So, when we first started thinking about metastasis, it was with this notion that cancer cells work alone. An individual cancer cell acquires mutations, and those mutations give each individual cell a competitive advantage to outgrow its neighbors invade, and ultimately metastasize to distant sites. What we and others in this emerging field have discovered is that cancer cells don't simply work alone, they actually work in many cases together. And when they work together, they're much more effective at the metastatic process and resisting cancer therapy. Now, let's unpack that idea a little bit more. So what we found is that when cancer cells work together, they're actually physically connected. They're connected through these molecules called cell adhesion molecules, kind of like sticky glue. And when they are physically connected, we find that they are 500 times better at forming metastases, 500 times. So we really wanted to understand, among many questions, how that works. And so when we drilled down into these physical connections, we discovered a compartment, a nanoscale compartment called nanolumen, which is basically a pocket where signals can be passed between one cancer cell to another. Now, these signals turn out to be absolutely vital for the outgrowth of cancer cells and their ability to form and expand metastases. I could keep going on, but Nancy, you have it.
So how's this going to help us? What does that knowledge mean as you think about how this might ultimately translate into the clinic?
Yeah, absolutely. So what we think is that nanolumen are a promising target for cancer therapy. A lot of cancer treatment is focused on molecules expressed by individual cells. What we're proposing is that there is this open space of molecules that exist that signal between cells. For example, we think that antibody-based therapy might be directed against the targets within the nanolumen. We find that the concentration of these nanolumen proteins might be 1,000 times higher than outside the cell. That's really important. Another aspect is that we think that these nanolumen represent private microenvironments. I think that there's a lot of potential to connect this to immunotherapy treatment. I mean, we can now start to ask, how do immune cells access these compartments? How might that impact our ability to target cancer in that sense?
You, like me, the two of us are practicing medical oncologists. We take care of men and women who have breast cancer at all stages, including individuals with metastatic breast cancer. I shared with the group briefly just a couple of things that I think are of interest that have been on the horizon and are on the horizon. But what's your view? What do you think are the most promising treatments for metastatic breast cancer right now?
I mean, this is a huge question, Nancy. But I think that one area, for a long time, for instance, triple negative breast cancer, ER negative, PR negative, HER2 negative, there have been a lack of therapies. As you mentioned, there's primarily chemotherapy is the choice for treatment. But I think I've been really interested in the development of these antibody drug conjugates, these ADCs, where you can couple a very toxic chemotherapy, but in a focused way to an antibody. A good example of that is sacituzumab, which is basically an antibody against TROP2, a stem cell marker found in many triple negative cancers. And by coupling that to a chemotherapy, you can deliver very high concentrations of chemotherapy to the cancer cell. And I think that's exciting because it's a general approach that may be applied to many targets, maybe even one day to these nanolumen targets as well.
Kevin, there's a lot of excitement about the whole field of what we call CAR T cells, cellular therapy, which has come into play for metastatic tumors of other types, particularly some of the blood cancers. Can you see a way forward for that in the breast cancer space?
I think so. There's, what's in the news, there's mRNA vaccines with the ability to genetically engineer the immune system and harness its power to provide durable responses for cancers such as metastatic breast cancer. That would be very exciting. So I think this is certainly a place here for Hutch that is well poised to apply such technologies in this way.
And if we think about some of the possibilities for advancement in the relative near term, according to the subtypes of breast cancer, you mentioned some of the work in triple negative breast cancer. What's your take on what's going on in the estrogen receptor positive space, the hormone receptor space, in terms of things that we should be looking for?
Well, Nancy, I should be asking you this question as one of the the sort of very important people in the field. But of course, I mean, I think we all appreciate that estrogen receptor positive breast cancer is ultimately driven by these signaling networks that rely on estrogen at the top, but through a number of very important receptors, both estrogen receptor, progesterone receptor, androgen receptor potentially. So I do think that, when we think about therapies, we want something that has the ability to generate a complete response. We want something that, could be highly durable. In theory, we don't have that, but like something you give once, even, and something that's non-toxic. And I think for many of the folks, including probably in this audience, we all appreciate that, medicines against the estrogen signaling axis can be toxic too and be difficult. And so I think that newer therapies that might provide both an ability to overcome resistance, but also hopefully be less toxic will be important for many patients. And that's ultimately why we're doing all of this that we're doing here.
Couldn't agree with you more. I think these are really top priorities. And in the HER2 space, just over this last weekend, we had the chance to hear about the results of a very large trial that was reported at the European meetings for medical oncology, which is looking at the nuances of how we treat HER2 positive breast cancer, trying to take some of these newer therapies and figure out which are the ones that do exactly what you said, provide the most efficacy with the least toxicity. So this refinement continues as we speak. Another important subtype of breast cancer. Another area where there are a lot of inroads, and which we might discuss a little later because I want to get to Lynda here, is things that have to do with monitoring. You're doing some work monitoring circulating tumor cells or circulating clusters. Others are looking at circulating free DNA. And of course, there's a lot of work going on here with our imaging colleagues, trying to do what we call functional imaging to try to look at metastatic cancer and get a sense of not only where it is, but whether it's likely to respond to a particular therapy or not. And so we might come back and talk about those topics after we have a chance to hear from Lynda. Thank you, Kevin. Now, I want to be able to bring Lynda Weatherby onto our stage today. Lynda is a patient advocate. She lives with stage 4 breast cancer every day. She was a co-founder and chair of the annual Northwest Metastatic Breast Cancer Conference, which I had a chance to attend a couple of years ago. And she serves on the executive group of the Metastatic Breast Cancer Alliance, and she is a very generous supporter of the Hutch's Metastatic Breast Cancer Research, for which we thank her. Lynda, I wonder if you could spend some time telling us a little bit about your personal story and why Fred Hutch Research is important to you, and bring us up to speed about your journey.
Okay, thank you, Nancy. I will definitely just be straight up and say that I owe my life to people who work at SCCA and the Hutch. I hope that my comments are inspiring, hopefully for anybody who's newly diagnosed in the group especially. And long story short, 20 years ago, I was diagnosed with an early stage DCIS, stage 0 DCIS, and had a bilateral mastectomy and was determined not to need chemo or radiation. I had a 2 to 3% chance of recurrence, we thought. And basically, I started living what Kevin is studying. I always am interested in hearing him talk because I know that he's looking at it in the lab, and I was experiencing it in my body. 12 years after that stage 0 diagnosis, my MBC was discovered by accident at a very urgent kind of acute emergency room visit weekend, and I was swept back into the care of my oncologist at SCCA. It had spread throughout my bones. It had gone to my brain, and I had a really terrible tumor on a facial nerve, that kind of the worst pain I've ever experienced. I was treated with Gamma Knife through the SCCA and Leah Hallis, who an incredible brain radiation doctor. She treated my brain and the facial tumor. And then I've been managing my bone mets ever since, and I'm 8.5 years out from that experience. I have experienced progression, and I've mutated. This is something, for newly diagnosed people, you'll hear about this, that my cancer mutated from being estrogen positive to, we think maybe 2 years ago, it started to change to androgen receptor positive. which Kevin mentioned. And that's been challenging. And so I'm on my first chemo in 20 years of breast cancer. I'm on my very first chemo. It's oral. You don't lose your hair, obviously. Challenging to manage. We've had to reduce the dose a few times, but we're figuring it out. I'm on Xeloda for anybody who may be on that. And I'm happy for anybody to reach out to me if you have questions or want to know, more about my particular path. I will say that I've gotten very involved in advocacy as a way to kind of deal with all of this. I was a healthcare professional, healthcare administrator before I was a patient, and it's in my blood. I love working with physicians, and I just felt like we needed to make it better. And all of us know, despite all the efforts going on at SCCA and other wonderful places around the country, it's never enough. We are dealing with a life-threatening disease. Even when it's stable, it's still life-threatening because it can change from, we know, I'm monitored with PET scans like most of you probably every 3 months, and it can change from scan to scan. And tumor markers go up and down. And so we're never not living with it. In many cases, it's a full-time job. So I'm here as a motivator to say, let's be a community here in Seattle that really embraces the work that these wonderful people are trying to do. And I really hope that this is the beginning of something where they can come back to us as a community and tell us what they're doing and tell us what they need. And I'm very sensitive to not raising money on the backs of patients. Patients have enough going on. Many are on disability. We all know that story. Let's reach out to our communities of people who may be in a position to really support this kind of research and build something that will drive the Fred Hutch's work forward. That's my wish today. I'll also say that October's coming up, and we all know people who want to support breast cancer and they just donate to pink causes because it's Breast Cancer Awareness Month. And frankly, for a metastatic patient, it's kind of a painful time because we're not dealing with prevention and early detection. We are so far beyond that, and the life that we live does not even begin to look like what you see in Breast Cancer Awareness Month usually. So we're trying to carve out something different here where we can really drive home answers and treatments for people already living with metastatic disease. I will say that for this event, a very motivated and generous donor has promised a $30,000 matching gift for anything that we can do in this event. And the 30,000 number is representative of the 30% of breast cancer diagnoses that will either be diagnosed metastatic or will become metastatic like mine did over time. And so if you're able to donate, great. If you are able to share it with people in your world who may want to support your journey or have known or loved someone else who dealt with metastatic breast cancer, please share this link and let's see what we can build here. That's my hope for today.
Lynda, thank you so much. I just, hearing your story for the first time, we haven't met before. It is so harrowing to hear all the difficult parts of the last years, and I'm so sorry. I take some solace in the fact that you are obviously weathering it well, or at least the best you can at this particular point. And I'm hopeful that you have been able to take advantage of some of the inroads that we're making. And I am very grateful for the fact that you're trying to help us to give the support to make the next set of inroads. So thank you so much for sharing. And thank you so much for your support. We really appreciate it. Now, in these next few minutes, we have the opportunity to think about questions. And a number of you have already been online and have sent us some possibilities. And so I'm going to pick a couple here that Kevin and I are going to try to handle. And where necessary, we're also going to have the opportunity to take advantage of Lynda's expertise. And so I'm starting with one here that has to do with what's happening in terms of treatments with curative intent for those with metastatic breast cancer who have a low tumor burden at diagnosis or who have responded well to treatment. And so I think this is something that, Kevin, we sometimes called oligometastatic breast cancer. And this is the concept of somebody who has breast cancer and who has a single site in the bone or something like that. How do we think about them? Do you want to give us some thoughts about that?
I think this is a very important question and area. You know, the challenge is that when we define oligometastatic, we define it, we rely on imaging. And the problem is that imaging in its current state of the art is only down to about 0.3, 0.4 centimeters. And so as an oncologist, what we would advise is that what we can see is potentially only a subset of what is there. At the same time, I think this is an immense area of interest because we know that, for instance, ideally in a perfect world, if there were the right tumor markers or liquid biopsy technologies that would let us know to the depths that's sufficient of the amount of minimal disease there is, or if there is no disease, then it should be possible to achieve curative intent. I think those are anecdotal, or there are examples and case reports of such things being applied. And certainly in different tumor types, there is a lot of interest in treating oligometastatic disease, for instance, with radiation and other approaches. So I think there is a lot of potential.
Yeah, I couldn't agree with you more. I think this is a really active area of research across a lot of what I would call solid tumor research. In our colon cancer colleagues, they've learned that the biology of metastatic colon cancer is such that sometimes they do surgical resection, for example, of liver metastasis, and they see very positive benefit with that. In the metastatic breast cancer space, that hasn't been quite as promising so far, but I think you're right that this is an area that's ripe for investigation right now, because when you think about this, you have to have a couple of things. You have to be able to detect disease, as you talk about, and then you have to be able to have effective therapies. And that takes the form of radiation therapy. Sometimes it takes the form of surgery, but often it takes the form of drug therapies. So unless you have those drug therapies, you're not going to be very likely to be successful. But please rest assured, listener who asked this question, that there's a lot of work going on right now in the breast cancer space. And we're actually thinking about even clinically. In May, I had a chance to attend, as did Kevin, our professional society meeting virtually, because everything is virtual. And so one of the sessions that I went to in the educational session was exactly your question, which is, where are we right now when we think about what we know about patients who are in this space, and how should we be using our knowledge right now to help patients today while we're learning how to take it forward in the future? Now, another question, very different topic, and I'm going to confess my ignorance right from the get-go, Kevin. We'll see if you can help or not. One of our listeners is interested in a compound called capital E, small r, capital S, capital O. It comes from Dr. David Shapiro. He's at the University of Illinois. He's a biochemistry professor there, and apparently he publishes in Science Translational Medicine. And his agent has been got exclusive licensing rights to Bayer. So I'm not familiar with it. Are you, Kevin?
I have not followed that small molecule, but it is a small molecule that I think it's suggested may have an effect in estrogen receptor positive breast cancer. I think that there is the road. There's something called the valley that it's very hard to go from basic science to early phase clinical studies, or even advancing to ultimately the drugs that we can give to patients. And so it is absolutely important that promising drugs in the laboratory, that there be investment in bringing that forward into early phase trials. And it's through support through folks like in this audience that's possible.
Yeah, I couldn't agree with you more. Breast cancer is a very, very ripe field for development of new agents, especially now that we understand more about the subsetting of breast cancer. And so I think that there's a lot going on in the academic community, like we're trying to do here. There's a lot going on in pharma, and making those connections and trying to make sure that we rapidly and safely develop the most promising agents is a top priority for, I think, all parties who are part of this process to try to develop these therapies. I think our increasing biological understanding has actually helped us to accelerate this. if you think about over the last several decades, the period of time to develop, for example, the PARP inhibitors. I'm thinking that the first report about the PARP process was really like in 2005, I'm thinking, Kevin, something like that. And here we are in 2021, and we have a multitude of PARP inhibitors that are available in the clinic that we can use to treat a variety of tumor types, including certain kinds of breast cancers, but also certain kinds of prostate cancers, ovarian cancer. So that to me is an example of how knowing biology can really accelerate development. Of course, 15 years is way longer than we want, but I think we can hope that we're going to see a collapsing of that timetable with time because of our increasing biological understandings. I also was asked about lobular breast cancer. Do you want to say anything about that?
I think lobular breast cancer is immensely important. It's like affects many of our patients, and it has properties that are, I think, very distinct from the ductal carcinomas and are also very important to investigate. It's an area that in my laboratory, for instance, we've thought about going into lobular, but it's about, enough staffing and funding support. But this is an immensely important area because, lobular has a tendency to be very insidious. The nature of these cells that they form these streams of cells that are difficult to detect on scans. And oftentimes clinically we have a challenge, a dilemma as to whether the patient is progressing or responding to treatment. These settings can sometimes be confusing. So it's in a very important area. Is there more context to that question? Nancy?
No, I think one of the questions is what kind of research we might be doing on lobular breast cancer here at Fred Hutch. And I think the answer here is, first of all, I have a personal interest in lobular breast cancer. I've worked in that area for a long time. So we do some of our work across consortiums. One of the groups that I helped found is something called the Translational Breast Cancer Research Consortium, called the TBCRC. And we founded that now also about 15 years ago. It's a group of 18 cancer centers across the country that are very, very driven to perform trials that look at biological hypotheses in small trials that take advantage of collecting and interrogating biospecimens. So trying to really understand what's going on in the lab, translating into a small clinical trial, and doing the sort of work that's necessary to see whether these positive findings in the lab can be recapitulated in people with metastatic breast cancer. One of the trials we have going on there is actually in lobular cancer. And it's what we call a window trial. So this is taking women postmenopausal women, who have been diagnosed with lobular breast cancer. And one of the questions is there a right hormone therapy for these women? Should it be tamoxifen? Should it be fulvestrant? Should it be the aromatase inhibitors? What would that look like? And so this trial is actually asking women with this newly diagnosed lobular breast cancer, as they're getting ready for their surgery, be randomly assigned to one of those 3 FDA-approved agents for the treatment of breast cancer, and then to allow us to do biological specimen collection, to take tumor at the time of surgery, and to interrogate it for particular markers and see whether or not we can see a better biomarker modulation, one that might be more favorable with one agent versus the other. So that's the kind of research that's going on in a disease like lobular breast cancer concretely now in the clinic, trying to understand if one hormone therapy might be better than another. Lots of work going on in the laboratory, as you talked about, Kevin, trying to look about where the commonalities are with ductal cancer, the much more common subtype. What things do they have in common, and where might they differ, and how can we be thinking about this going forward? So stay tuned. There's also a really terrific Lobular Breast Cancer Alliance, a wonderful advocacy group that works pretty actively with lobular breast cancer researchers of one sort or another to try to make headway in this particular field. Now, a question here, just to go back to some of these targeted agents. So triple negative breast cancer. PARP inhibitors have come on board. You talked about the new conjugate. Are you aware of other agents? And we talked about the checkpoint inhibitors. Are you aware of other agents that might be coming up that we're looking at in the triple negative space that might be nearing some sort of use in the clinic?
I think that the application of those drugs in different contexts is becoming more and more. So in the near term, from a patient perspective, I think that I always tell my patients start with, where is FDA approved, where there's the most clinical data. And I think the use of these drugs in combination with other agents together, for instance, combining, let's say, PARP inhibitors with immunotherapy or ADCs with immunotherapy, is something that in the near term probably could have even more benefit. There are many earlier phase trials, certainly including here at the Hutch, that may look at the role of immunotherapy in different contexts to ask whether that might help patients. But there are also earlier phase trials have their own risks as well. So something to consider.
Now, lest we have this be drugs, let's think for a moment about lifestyle. And are there, if we back up a little bit, I know that this is a forum on metastatic breast cancer, but one of our listeners has asked whether or not there are lifestyle or dietary changes that might help to reduce the risk of relapse. So perhaps just a little bit farther up, do you have comments that you'd like to make about that, Kevin?
I think that the notion, there's different pieces of that. I think certainly exercise is an area of significant interest in the cooperative groups and in large studies. We know there's an association between obesity and risk of recurrence. So what you can do to reduce your BMI, increase your muscle mass, it's thought that could prevent risk of recurrence. I do think that there are a number of studies in the literature talking about the use of vitamins or changing your diet in different ways. I do want to take a step back, which is that sometimes vitamins don't work the way we think they do. There are studies that show, for instance, that antioxidants, while you might think they might prevent cancer formation, actually allow cancer cells to better metastasize to sites. And in fact, there was a published study in the SWOG trial showing that the combination of antioxidants with chemotherapy might be associated with worse outcomes because antioxidants might allow cancer cells to survive chemotherapy treatment. So I would say that a healthy diet is important, but maybe talk to your doctor and your team about whether certain vitamins and other things.
Yeah, I want to amplify on that a little bit. And again, knowing that we're speaking largely with individuals who are very concerned about metastatic breast cancer, I know, though, that you have a pretty open interest in all things breast cancer. And so I wanted to reflect for a moment that, we are not wholly focused on drugs. And a couple examples I wanted to give to you. One, locally, I want you to be aware of the fact that our colleague Heather Greenlee, who is an interesting person, she's a naturopath and a PhD researcher. And she is very, very interested in trying to bring a rigorous approach to the study of lifestyle changes of various sorts in the setting of breast cancer. So, for example, one trial that she's allowed me to piggyback on a little bit has to do with women with early stage breast cancer, but trying to think about nutritional interventions, teaching them healthy cooking techniques and whether this is something that will allow them to improve not only their breast cancer health, but also ultimately their overall health. She does this through a kind of initiative called Cook for Life, I believe, that's on the Fred Hutch website, and you can certainly take a look at it. I've been excited about this because Heather was doing this in New York City, which is where she lived for quite some period of time till she transferred here a couple of years ago because she thought her research would fit in very well with our public health concepts and our public health perspective as we think about cancer writ large. And so she's now brought these initiatives here, and she's trying to think about them not only in the global population, but also in specific populations. So, for example, she's been very focused on thinking about this approach in Latina breast cancer survivors in the recent past as a way of trying to focus on their particular situation. So from my point of view, extremely exciting. Our colleague Ann McTurnan, also in the Public Health Division, has been very focused on exercise. Thinking about it in cancer generally and breast cancer specifically. And I want to tell you at the national level, members of the audience, that in the setting of early breast cancer, we as taxpayers, all of us, helped to support a trial done at the national level across our country, looking at the concept of weight reduction as a form of therapy for early breast cancer, just in the same way you'd use aromatase inhibitor or chemotherapy. The question is whether if people go into a rigorous program of weight reduction, whether this will have positive benefits that we would be able to measure in the same way that you would measure the effect of a drug. I'm happy to tell you that thanks to many very supportive women across the country, that this particular trial has accrued. All of the participants are now on the trial. Half of them are having a sort of standard approach, half are having this more tailored effort to try to help them to do weight reduction. And the hope is in some years' time that we will be able to show that this has an effect on recurrence of breast cancer, and that there would be a way that would be able to describe for people how they could best take advantage of this as an intervention in addition to the more standard medical treatments. So this is an extremely exciting area from my point of view, something where we're trying to look very holistically at how we as a community can help people to control breast cancer. Paging through here, I see here's a question that I'd also like to put out in a more general way, and that is that, Kevin, some relatively small but important fraction of women, including one of our questioners, have the bad fortune of coming in with metastatic breast cancer at the time of diagnosis. So they come in with this breast mass, and in the context of evaluating them, it becomes clear that the breast cancer has obviously spread elsewhere in the body. And so there's been quite a lot of discussion about the best way to approach those patients. And in particular, one of the big questions is whether or not it makes sense for them to have a mastectomy or to have a lumpectomy to remove the primary tumor as a part of their treatment. Can you comment on that?
Yeah, I think I'm on two minds of that. That's obviously, if from a basic scientist or laboratory-based, we think that the goal is to get to cancer zero. We want no cancer in the body. That gives the person the best chance of, having a good outcome. So, a priori, you might think that get a mastectomy and have that removed, and that would give you a better chance of surviving and living and getting past the disease. But there have been a number of larger, medium-sized clinical studies where people have tried to explore this, primarily in countries outside the United States, and with mixed results, and I would say not particularly convincing that it's like, this is what you should do. And so I think that it's an active area of investigation. It may relate back to this question we brought up earlier about oligometastatic disease. It may be that there are sites that you can't see, so even if you remove the primary tumor, we haven't dealt with the fundamental problem, which is we need to have therapies that effectively target cancer cells, whether they are in the breast or outside the breast.
Yeah, I agree with you completely, Kevin. Several of our questioners have gone off are oriented in this direction, and I think Kevin is absolutely right. That our concept has been that if one has the great misfortune of presenting with the primary tumor and overt metastatic disease, that is obvious metastatic disease elsewhere, that we have really focused our attention on the disease elsewhere because we think of that as the most serious, at least at the beginning, and so the place where we need to make the greatest inroads. But there has been some thought that if one uses the drug therapies that we have available to us, for example, like anti-HER2 therapy, and gets pretty good disease control elsewhere in the body, should you come back and think about this breast lesion again? I agree with you, Kevin. Several of the first trials, the randomized trials to do this, were performed outside the United States. There was one that was actually done in our country that just came out in the last few months that looked at this question. And the design was people with metastatic breast cancer at the time of presentation in the US, and basically randomly assigning them to our standard therapy, which is to use drug therapies as necessary, and to use surgery to the breast only if the breast tumor becomes a problem, it becomes painful, or it requires palliation. And then the other group of women had those same drug therapies, and if they did well with the drug therapies, then the surgery would be applied at that point. And what we found, to our sorrow, was that the two groups of women basically did equally well. Or maybe that's to our pleasure, because it says to those folks that they won't have to undergo that breast surgery. So that, I think, is the current state of knowledge that we have in this particular field. Please rest assured it's an area of tremendous interest. And certainly it's a small but mighty subset of metastatic breast cancer patients where there's a lot to be learned. And one of the things I think we're very grateful for is that those individuals have signed up for some of these clinical trials that you and I just talked about. And some of the things that have come out of this are actually some pretty rich biospecimen banks. And so with time, we'll be able to use this to try to help us to think about what we can learn that would help us to improve the situation in that particular setting. Now, on a related note, one of our listeners wants to know, so if you were in that setting, or if you got a positive response to your treatment for metastatic breast cancer, to the point that you're viewed as being without evidence of disease or without evidence of active disease, is there a role for radiation or things that we would normally use in the curative setting?
So yeah, I would agree that, so in terms of radiation, we oftentimes think about it as a means to alleviate symptoms, palliation of symptoms, and that's very important. That's sort of the paramount decision or thought process. But certainly there are cases when you have, it's on a case-by-case basis. If you have a patient who has a great response, and has that solitary lesion we talk about, and over a course of a year, a couple of years, we feel all very good about it. These things come up, and I think if the situation arises, that could be definitely a possibility. So I think it comes down to what is the true level of disease that is in the body. We need better tests, liquid biopsy and others that would allow us to deeply monitor and determine what is there and or not there.
So a 2-minute answer for this question, because we're coming more towards the end of our discussion. Kevin, some of our listeners would like to know what you see are the next steps in your research. What are you really thinking about is going to happen in the next year or two? Or what do you want to happen?
Yeah, well, I think, we talked a bit about the liquid biopsy piece. I do think that there is still immense opportunity in this space. And certainly my work is responsive to my patients that I see in the clinic, the patients, such as the patients in this audience too. And really one of the key questions is that, we get a biopsy at diagnosis of cancer, maybe at the time of surgery, maybe at the time of recurrence, maybe again 1 or 2 times. But that means that for the large span of a metastatic breast cancer patient's diagnosis, we actually don't know really what exactly is going on. And I think that the ability to reach deep into just a simple blood sample and learn as much as possible about what the cancer is doing, how it's resisting, and how we may adapt and evolve our treatment strategies, that's key. We really don't have enough data yet to apply, let's say, machine learning or artificial intelligence. But I could imagine that in the future, if we were to have that potential to sample deeply in individual patients, we might be able to harness that type of technology to yield more intelligent decision making.
I'm going to just add one other area which you and I are both watching with great interest and supporting our fellow researchers here, and that is this whole area of functional imaging. I think that everybody on this call, I'm sure, is very familiar with traditional imaging for cancer. You know about CT scans, you know about MRI scans, you know about PET scans, you know how we're trying to combine those kinds of modalities. And a frequent test for metastatic breast cancer, as I think you heard from Lynda a little while ago, is a PET CT, right, which allows us to image areas of tumor within the body and also use the PET part of it to try to decide whether or not it's an active tumor, whether it takes up a lot of glucose, suggesting that it's a growing and active tumor or growing and active lesion. So, there's a lot of interest in whether we can try to hone that a little bit. And our colleague Hannah Linden, for example, and our radiology colleagues are trying to look at whether or not they can use a different kind of tracer than PET, something that would allow them, for example, to be able to tell whether or not a metastatic tumor is likely or unlikely to respond to hormone therapy. So they can image that, use a PET CT variation, if you will, with a different kind of tracer, and then to do a challenge with the agent in question and see whether or not it looks like it's likely to respond in a short period of time in the kind of imaging that they can do. And that could be extraordinarily helpful for us to try to help people to figure out, here's a new therapy, is it likely to work or is it at least less likely to work by virtue of how it modulates the imaging? So this is very, very cutting edge work. This is, the first such tracer, an estrogen-based tracer, was just approved in the last couple of months, and we're trying to think about how we're going to bring it into practice. And there's a lot of interest in whether or not there are other kinds of approaches like this. For example, can you figure out how to use this to look at response to PARP inhibitors? So stay tuned, because functional imaging, it's called, we hope is also going to be a pillar along with our traditional imaging and along with the biopsy techniques that Kevin talked about, and along with the whole idea of the ability, we hope, to do serial monitoring of blood in a way that we can get a longitudinal sense of how the tumor is evolving, and try to think about how we can then use that to counsel patients about the best approaches for them. Now, in our last little bit, I would like to bring Lynda back on to be with Kevin and me, because Lynda, there's some questions about where people can get more information on fundraising, on awareness, and how they can become more involved in the advocate community. So could you help us with that?
Absolutely. I want to say that there are a couple of people on this call too who are wonderful advocates, Terry Palastro and Diane Mapes. We are all on Twitter, and I'm happy to post my email and cell phone if anybody really wants to connect and learn more. There are organizations out there that are really focused on metastatic breast cancer, as opposed to the whole, scale of breast cancer from early stage to late stage. The Metastatic Breast Cancer Alliance is one organization that works with industry and nonprofits and patient advocates. You can apply to be a member there. That's one that Terry and I work very closely with. I would say that, again, I'm hopeful that we can build a community here. And maybe after this call, we can find a way to connect people. There is a Seattle Metastatic Breast Cancer group on Facebook. You can look that group up. I think you have to be admitted. You have to give your details of when you were diagnosed, just because it is for patients. That is a way to start to reach out to other patients, and you can learn more about what other patients may be doing in advocacy. But I think that for people who want to get involved in advocacy, probably best to maybe reach out to Terry or me, and we'll find out what you're interested in, and we can help you get connected to more national organizations. And stay tuned here for ways to engage with the Hutch.
Lynda, I hope you're going to stay online because we have a couple extra moments. I'm going to tackle a couple of other questions between the three of us. Kevin, first, a point of clarification from one of our listeners. She wanted to know whether she understood you correctly that antioxidant food and or supplements could actually allow cancer cells to stay healthy and multiply.
That is correct. Yes, there are studies that have shown, both in the lab and in the clinic, that antioxidants could be bad for you. So I think that's like on a case by case basis. Talk to your provider.
Yeah, I'm going to amplify what Kevin said. I think that I think we are all, as providers, very respectful of the fact that there's a lot of information out there, and that you're trying, as a metastatic breast cancer patient or a loved one, to sort through it. I also think that, we do take pride in the fact that we think there's a pretty deep science between the kinds of things we try to recommend to you as providers. But we're respectful of the notion that, we're sitting in the provider seat and you're sitting in the patient or the caregiver seat, and you want to learn as much as you possibly can. So what I ask, and Kevin, I suspect you do too, is I ask anybody who's under my care to come and talk about what he or she is thinking about. If you're thinking about what I would call a complementary and alternative therapy, let me know what you're thinking. Sometimes I may say, sure, why not? Sometimes I might say, as Kevin said, I'm worried that there's some information to suggest that this may not be in your best interests. And often, of course, it's a black box. We have no idea because these things haven't been rigorously studied. But I think that it is probably in your best interest to get some input from your provider on this. And then once you make a decision, because our job is to give advice and your job is to figure out what to do with it, let us know what you decided so that we can work with you on it, right? You may or may not agree with what we recommend, but it's our goal to understand where you're coming from and what you're doing so that we can try to make the best possible approach together. I also want to remind you that Heather, who I mentioned to you, Dr. Greenlee, not only is she very interested in that diet piece, but she's the leader of our integrative oncology service at the SCCA. And so sometimes folks will come in for a holistic consultation with our integrative oncology group about the other kinds of things that they might bring to bear to maximize their care. And they might also hear about the things that they probably shouldn't bring to bear if they want to maximize their care. Another question, which I'm going to take near and dear to my heart, is what do we know about the evolution of metastatic breast cancer? Might it change these subtypes? Incredibly important area. Another place that we are as a field trying to address, and I want to go back to a big national initiative right now, something called the Aurora Project, which has actually looked across the country to try to identify tissue specimens of the primary tumor and the metastatic sites from women, in this particular case, who've had metastatic breast cancer, and then bring them to the laboratory and interrogate them deeply, deeply, deeply with all of the different so-called omic technologies that we have available to us these days. Genomics, proteomics, lipidomics, metabolomics, et cetera, et cetera. So that's going on right now. And we're doing this first in a retrospective way. That is going back and trying to collect these things that exist in tumor banks, and our US results are just coming out on this, and so we'll know more about this switching. We also have a prospective trial going on at the multiple centers across the country through that TBCRC that I told you about, where we're asking individuals with newly diagnosed metastatic breast cancer or with metastatic breast cancer, if at the time of a biopsy, they would allow us to recover a research biopsy and take that to the laboratory in conjunction again with their original tumor and do that kind of interrogation in a prospective fashion. So please know that this is an area of very active research across the country. We here in Seattle are working very actively with the TBRC and the Aurora Project to try to get these biospecimens that are so necessary to figure out some of the things about this switching. Well, we're down to our last 2 minutes. And so first, I want to thank all of you participants online. Some of you asked pretty specific questions about your own situation. And I think what we might try to do is to ask our team to get back with you in some fashion to provide whatever guidance we can, realizing that unfortunately we cannot substitute for the guidance that you're going to get from your primary oncologists, and we would urge you to go back to them. I also want to thank Dr. Cheung, both for being here today, to be such an articulate spokesman about the kind of research that he and his team are trying to do, and to provide us with some insights, looking into the lens of where we're going to be going. And Lynda, we cannot do this without you. It really is, the team is centered around the patient, that everything we do is for our patients and for their families. And we are so grateful when you are willing to partner with us as you are in so many ways. So thanks to all. We appreciate your interest, and I hope you found some useful resources in terms of our websites. And I believe this is being recorded, so you'll have the opportunity to share it. Thanks for joining us. Happy fall. I think we're just about to come into the beginning of the fall season, and I wish all of you well. Thank you.